really excited today to be chatting with industry experts about the topic of predictive analytics in home health and hospice. My name's Katy Lanz. I am a nurse by trade, nurse practitioner, and spent the first decade of my life at the bedside in a hospice in North Carolina, and then as a nurse practitioner in various settings. And then the last 10 to 15 years in the value-based integration environment for community-based services for the seriously ill. And data has been a major friend in that journey because it has allowed both at the bedside, the practitioners, for myself and others, a really robust environment to have better insight into what's happening, both with our patients, our partners, and our fellow coworkers. But there's so much that has changed, especially post-COVID, for the home health, hospice, and serious illness population management industry. I currently am serving as the Chief Strategy and Product Officer at Personal Care Medical Associates, and also the principal at Topsite Partners, where I advise companies. And today I'm thrilled to be invited by Hospice to help moderate this webinar with these fabulous three gentlemen and people that I deeply respect, who have been very committed to the industry and helping support similar initiatives in managing the patients who are experiencing serious illness and beyond in the community-based settings. What I plan to do today is allow them just basic time to talk about who they are, what they're up to, what they, the impact of their work within their company. And then we're going to explore through question and answer series where they see things headed and how they're trying to adjust to accommodate that, who the new players are and what they're asking for and how they're responding to that. And I think, then even predicting further upstream is that, how do we anticipate things happening, in the 3-5 year mark from now, and what things will look like. As a provider, it's really hard to make decisions about who to use, what to use, and what's going to give us the best bang for our buck. And so I also want to take a lens. We have a really diverse audience who have signed in to join today, coming from all different sectors, but all in the industry, it looks like, of community-based seriously ill care. And so also sometimes institutionalized as well, but we'll be really focusing on that environment and that audience. I do encourage you to post up in the chat box if you have a question. Both Molly and I will be keeping an eye out for what's coming through and making sure that we get to a lot of the questions that are there. But I just want to say thank you again to Hospice. We're all trying to figure out how to do more with less. And I remember as a hospice nurse in the field, way back when, just having an alternative route to give medications was an incredible asset, especially for people who, couldn't swallow and were nearing the end of their life, but also when they just had temporary symptoms. So I'm thankful to be working with them because I believe in the tool and appreciate the platform to share this space with colleagues. So let's jump in, gentlemen. What we'll do is have each of them spend about 5 to 7 minutes talking and introducing themselves and their technologies, and then we'll get in the weeds about the fun stuff. Let's start with Tom.
All right. Thank you, Katy, and thank you, Molly, and Hospice for hosting this webinar. I'm Tom Maxwell. I'm the non-executive chairman of the board for Medalogix. Was also the co-founder of Muse Healthcare, which was bought by Medalogix in the Vistria Group. I'm also the co-founder and chairman of Maxwell Healthcare Associates, so that's where I spend most of my time between these three companies. By way of background, I was the chief operating officer and chief strategy officer from 2005 to 2016 for Home Care Homebase. So that's where I got deep into the home care and hospice space. Prior to that, I was in the practice management business, and then before that, I was actually with the Marines and then the United States Navy as a hospital corpsman, so run around the country serving all those guys. Let's jump into the slides if we can. So Medalogix, who are we? So we're dedicated to empower individualized patient care with innovative data science-driven solutions. And so our real goal is the intersection between healthcare and technology for home health and hospice. We were built by clinical expertise. I and myself spent many years as a clinician, and we're really focused on in-home care, so only the home care and hospice space. We serve about 30% of the home health industry today, are the patients that run through our platforms, and about 22 to 26% of the hospice industry, and about 450,000 home health and hospice patients every single day are on the platform. Next slide. So this is the reach. So number of patients that we've actually taken through the technology, about 12.1 million patients. So as you're looking at building technology and AI, and I'll talk to it here in just a second, having a volume of patients that look the same or that have same characteristics is really important. We actually have patients in 50 states, about 5,170. That was as of this morning, Medalogix users, serving about 1,083 home health branches and about 1,066 hospice branches across the country. Next slide. So what's the products? The products, Pulse Bridge Muse, PBM. I know it gets confusing when you start talking about PBMs because most people think that's around medications, but we went with the Pulse Bridge and Muse. So Pulse is looking at your home health patients, and really we're trying to predict rehospitalization or how sick is Nana based on over 800 data elements that come in from every single point of care visit. So, excuse me, we pull those visits in and then we compare them. And so the difference between kind of what we're doing and the rest of the industry, we're looking visit by visit is how sick is Nana, how likely is Nana to rehospitalize. We're trying to reduce that by alerting you in different ways. And I'll throw a plug in for the Macy catheter here. We have scripts inside of our tools that'll actually look, especially on the hospice side, that will look at the characteristics of those patients and say, hey, can the patient swallow? Are they having trouble holding down fluids? Do they need medication administered in a different way? And we can actually predict to the clinician and say, hey, there's a possibility that you may want to think about, using one of the hospice products. So that's what Pulse does. Pulse is really identifying home health patients in the trajectory. Not only are we looking at recertification, we're also looking at that high risk for hospitalization. But guess what? The good news is if I can predict they're not going to be, or they're going to be hospitalized, I can also predict they're not going to be hospitalized. And so we spend a lot of time analyzing patient by patient, not only comparing them to the 12.1 million patients that we have, but comparing Nana to Nana every visit. The Bridge product is a really neat product because it's looking at your home health patients and identifying those patients which have a mortality risk rate in the next 90 days. So these patients are on service in home health, but would benefit from the hospice benefit. And so there's a tool set that's been created that actually uses predictive analytics again and AI to predict those patients that you need to evaluate for hospice, because kind of our message here is no patient should ever pass away on home health. They should enjoy the hospice benefit. And the last tool, which I'm most passionate about because I founded the company with Brian Mosier and Jennifer Maxwell, is Muse Healthcare. Muse really focuses in on every single hospice patient. How sick are they? How likely are they to pass away in the next 7 to 10 days? Not because we want to get more SIA payments. That's part of it. The government wants us to do that. But how do we make sure that that experience where we have a clinician, we have a social worker, we have a chaplain involved in that patient's care in the last 7 days of life, so that no patient goes alone and no patient should pass away alone. And so Muse is using the data analytics to predict visit by visit, patient by patient visit, or every patient, every visit, to make sure that we're predicting when Nana's declining in her disease so that we can react different to that. So we see Nana declining, we can add more visits, we can schedule a physician to go out there, we could change behaviors, get fluids, put a hospice catheter in, order food, order water, handlebars, all those kind of things. So this is how we're really using AI. We'll get more into the details in some of the questions, but this is how we're really using AI and predictive analytics to help hospices and help home health agencies be able to provide better care to their patients at the right time. Katy, flip it back to you.
Thank you. I really appreciate that. And I think that you guys will see a trend, but differences in how each of these technologies, platforms is approaching things. And so we'll get into the weeds a little bit about that later, but thank you for that background, Tom, and history. Also, one more question for you, Tom. How long have Muse Medalogix Bridge been together now as a package of services?
So 18 months. So the Bridge and Care product, which is the original Medalogix products, came together with the Muse product about 18 months ago, 19 months ago. And then the Pulse product's been out in the market now for 6 months. It's a conversion of Care and then adding in the new visit by visit analysis. So that's been out for 6.5 months now.
Fantastic. Thank you. Thank
You
you.
bet.
Some things happened through the COVID period. And so
Yeah, who would have thought you could build a company during COVID, but we did. We started it. We took St. Croix live, which is our first customer. By the way, I see Dr. Mayo in the list. Hey, Dr. Mayo, but he was our first medical director to use the product. But we went live with Muse, and the same week that COVID hit. So kind of crazy.
Thank you. That's a nice suite for groups, especially who have services together, between home health, hospice, and or independent. So thank you. I appreciate it. All right, Wes, or actually is Jeremy next? I can't recall how we lined this up. It's Jeremy. All right, Jeremy, you're up. Thank you.
Thanks, Katie, and good job, Tom. It's always great to follow good colleagues around, and I'll do that again today. So a little bit about me by background. Like a lot of the team, grew up at the bedside in physical therapy, spent a handful of years there before following my dad's footsteps into technology, mostly realizing that we can use data to actually drive clinical and financial outcomes. And we've been doing that this leadership team's been together for about 2 decades, solving some of the biggest problems in healthcare, really addressing either centralized workflows that navigators, case managers, intake access administrator type folks do, and then the point of care clinicians. And so we'll sort of take you through a little bit of that journey as we show you some of the charts we've built for today's presentation. So if you think about what's happening in healthcare as a landscape, if you go to the next slide, there's a lot of attention being placed upon, next slide, there you go. A lot of attention being placed upon sort of risk-bearing entities marrying themselves to care delivery. And this is a very heavy platform. If it didn't have that marriage that's happening, and it has been happening in healthcare for the past 3 decades, certainly if you live in certain markets, you're familiar with capitated arrangements. That really was a primary care notion 30 years ago, and then with the Affordable Care Act, which the press calls Obamacare, that really became front and center for everybody in 2012. So you build a platform that's this complex, largely to solve reimbursement shifts, and that's what this is built for. So at the bottom of this chart are managed care organizations that do capitated arrangement, that are the risk-bearing entities. They could be an ACO, they could be a direct contracting entity, they could be an MSO. There's a whole flavor of groups that sort of manage that back office and revenue cycle side of healthcare. They can be the PBMs, and in this case, Tom, I don't mean your PBM, I mean the traditional pharmacy benefit managers, the medication side. They can be health information exchanges. They can be 48 different electronic health records that we tie into. And then when risk-bearing entities get involved, whether it's a health plan or a quasi-health plan, there's all this claims detail. So we actually pull data from about 10,000 sources, and we see, Tom, I'll use some of your vernacular, we see Nana's interactions across all of our care, whether it's institutional care settings, the hospital, emergency department, skilled facilities, rehab facilities, whether it's the audiologist that she sees because she's got a cardiologist, neurologist, pulmonologist, et cetera. Whether it's any of the care we're delivering. So under the paradigm where you might capture what's happening between Nana's this episode and next episode, we're also capturing all of the episodes. And to make this useful, it gets fed into the operating system. And that's where we build a single record for each of our patients. And then we can serve that record to logic, like artificial intelligence. Or at the top, you can serve it out to the patient and family and say, hey, we've noticed something different about Nana's behavior. Is there anything that you can tell us with patient reported or proxy reported detail? That next block over at the top, this SOA user, that's an application like an EHR or a case management solution, so that if I'm a natural worker inside of a centralized navigation world, like a case manager, I can work in my native system. So one of our large customers has built its own case management function. They don't know Acclivity exists at the end user level because all of our insights directly dovetail directly into their workflows inside of their own homegrown system. That can work in your world that way too. And then again, we'll always talk in our world about centralized workflow, the navigator case management folks, which we call population health, or point of care persons. This can be your social workers, your nurses, your physicians, any behavioral health specialists. They get their own workflows. And those are described on the right. They can be longitudinal over a pathway. They can be a convener because I'm tied to a contract and I get paid in a certain way for a certain behavior. They can be developing around best practices that are clinical or financial. And then they can look at a staff that's already burdened with COVID burnout, with staffing shortages, with a lot of very short length of stays in hospice, as an example, with OIG audits and those kinds of things. Our tooling does helps you sort of help that team be more successful in this kind of current paradigm. The reason we built this really complex view of a patient isn't because we're, just because we're geeks. We are kind of goofy and nerdy in that way that we like to tackle big healthcare problems. But if you look at this value-based care model, to the left of the providers where all the dollar signs are is the average golfer and dancer. Medicare is really a pretty healthy population if you look at them as a whole. And Medicare, CMS, Medicare, the plan side of Medicare puts a budget of about $10,000 per patient per year on the expected spend for a patient. So if you think about the way these programs work, so instead of doing a daily rate or a PDGM rate, and you're getting paid per volume, number of persons on service, number of transactions that occur, number of procedures you do, et cetera, this world is actually shifting you guys to have the budget. So if you take a traditional population in your catchment area and you look at them, it's however many number of patients you serve times $10,000 until they get sick, like hospice patients. Then that ratchets up to like $45,000 to $50,000. Imagine if you had, for every hospice case today, $45,000 to spend as a budget for every person that's on service. Do your math of your average daily census times $40,000. It's adult money, and that's what the federal government's putting in these value-based care programs as the budget. So instead of doing as many transactions, or in the case of hospice, as many persons on census as possible, and measuring how much we refer in a given day and what's our census look like, and watching that flow up and down, you're going to focus on that, but only as it pertains to managing the volume and the value of that encounter. Outcomes will be how many days were they at home in the last 6 months. Outcomes will be what's their hospitalization rate per 1,000. Outcomes will be what's their emergency utilization per 1,000. So under this program, the aha for all of us on the next slide is you take this risk, and that's what it's called, and you have the ability to actually get these budgeted dollars, whether it's a golfer and dancer community that's $10,000, or it's the institutionalized special need type patients that are in institutions or in house calls type practices or in your hospice. And you multiply that by 40,000 or 45,000, that's your budget. This is what a tool like ours gets to look at. It looks at which are my patients being served across hospitals, skilled facilities, oncology journeys, cardiology journeys, et cetera. And it looks at how many of them could I impact. And if I do a good job of navigating a very, burdened staff with COVID burnout, facing all the shortages we know about, and this reimbursement model, it's not scary when you look at it this way. What I'm showing here in the bottom two tiles are just a small subset of patients that are high needs patients, typically served by your palliative hospice, home health, risk-bearing entities and ISNP type populations. You can serve a very small part of that population and do really great things when your budget is $45,000 per year. So this is examples of customers using our solution. And this far outpaces the old world fee-for-service methodologies, because you would have to have served the number of hospice patients times tens of thousands to get to these numbers. And this is the check they got from these kind of programs over the course of a 1-year period. Back to you, Katie.
Thank you, Jeremy. And as I think about this, it is a shift. Having been in this industry a little over 20 years, how we both market for and get referrals in home health and hospice, but then also how we're evolving our service lines to either be a vendor to at-risk individuals, or build up our own at-risk environments. And I think the core of that is being able to prove it, right? And that's really hard to do in our current systems and functions. And so it's really nice to to see how you've presented that, because we can no longer, say the traditional outcomes that we once focused on and are accredited for. I think it goes beyond that. It's we have to actually demonstrate our value in the economic terms and be very specific about it and explicit and show it over time. So thank you for sharing that. And I certainly have enjoyed the product as well, and it's helped manage populations, and I've seen it evolve too. And so, each one of these toolings has evolved since I've been in the industry, and it's just so fun to see each time you guys give these presentations. And I'm excited to hear what's next too. So thank you, Jeremy.
Oh,
Yeah. All right, Wes is up. And Wes may not say it, but he had a baby the last week, and so, well, his wife had the baby.
Yeah, just to clarify, I didn't do any of the hard work there, but I was a participant in effect, but not putting any of the hard work in.
Well, we appreciate you making time for this and what is probably a sleepless time for you. Thank you.
Well, thank you so much, Katie. It's great to be here with Tom and Jeremy. I have a whole lot of respect for the organizations that they built, and I think all of us are trying to solve some of the same key challenges that providers are facing across the country. Again, my name is Wes Little, and I serve as WellSky's General Manager of our home-based care business, where we have a little bit over 10,000 home-based care providers leveraging our solutions in home health, personal care, and then hospice and palliative. And I also serve and lead our analytics team as Chief Analytics Officer at WellSky. So very excited to be here, have about 10 years in the home health and hospice marketplace, and are more excited and optimistic about some of the changes happening in our industry than ever before. So to tell you a little bit about WellSky, many of you might know us as an EMR provider, and that is certainly our initial legacy. We grew up and made acquisitions in the home health space, hospice, and personal care because we felt like there needed to be a best-in-class solution that spanned across all of home-based care to help serve all the many organizations that are looking to provide home-based care in each of these settings and wanting the best tools possible to manage their business in that part of the market. So we've had the ability to grow size and scale over time, and we also benefited from the fact that WellSky is a fully web-based solution across all of these end markets. And so we have real-time data being captured and collected across this entire industry, and the ability to insert insights back into the workflow of the caregivers that are actually out there in the field at the bedside. And, so having that connected network is really how we wanted to start building out our own analytics capabilities. And then we were able to accelerate this effort. Over the last year and a half, we've purchased the companies formerly known as CarePort and CureSpan, who really sit upmarket in the referral partners that many of you work with, who are sending out referrals to home health and hospice agencies across the country. And we felt like there was an opportunity to take some of that data and make it actionable to home health and hospice providers as well. And so really off of that knowledge and that data that we have, we saw three key trends emerging as major challenges for providers. First, and this is something I think everyone across our entire industry is facing, is the staffing crisis. The second is a focus on outcomes and driving more of those value-based metrics that will matter for both home health value-based purchasing, but also for working with referral sources and payers going forward. And then finally, for helping agencies grow their census and increasingly engage in more value-based contracts going forward with Medicare Advantage plans and at-risk hospitals and other groups. And so rather than look at each of these different problems individually and build a separate stack of solutions to solve each, we really thought that there was an opportunity to utilize a common data layer and set of insights these are all the same patients that you're managing for your outcomes. You also want to understand who are the right staff members to care for this individual patient. And all those insights about the patient are useful in understanding who the best person might be to care for them, and then how they're performing for that individual patient. In much the same way, you want to take those same risk-adjusted outcomes using your algorithms to help go talk to your key referral sources or payers about how you're performing with their patients. And so we've created a full suite of solutions, team insights, care insights, and value-based insights that are really focused around solving those three challenges that we see providers facing. And potentially at most interest to this conversation, I think where we see the most amount of overlap between the work that Acclivity and Medalogix do is in our Care Insight suite. This is a solution that incorporates on the home health side, hospitalization risk algorithms, hospice suitability, social and economic determinant of health insights, utilization recommendations, LUPA risk, and also now with our acquisition of a company called TapCloud, you can initiate virtual visits and do patient engagement from this solution. And so this is a capability that we've had in the market for home health for quite a while, but we are seeing an expanded increase of additional capabilities that are really responding to the needs of providers as they focus on value-based purchasing and other outcome-focused metrics that they want to be held accountable for, in addition to the growth that they want to drive across their agency. Our first predictive analytics solution that we built was actually for the hospice market, and it's called WellSky Care Insights for Hospice. And it focuses on 7-day mortality likelihood, revocation risk, along with schedule insights and SIA tracking. And it's all embedded into the core workflow of the EMR so that your clinicians actually have access to this information at the bedside. And I think we're going to talk about this in a little bit, but we've been very excited with the outcomes clients have had across both these solutions. And ultimately, that's our highest barometer of success, is the impact clients are able to make in actually caring more effectively for patients and being able to grow their business.
Thank you, Wes. And you know what? Why don't we just jump to that particular question about impact? Because you guys have just talked about what you're doing now, and maybe that's the first best, place to start. And I know each of you shared a little bit of outcome data, and I think the outcome data is different depending upon, i.e. the user and or the business structure of that user. But why don't we start, just Wes, since you were just chatting about yours, and and you can either categorize it, be it home health or hospice, but knowing the challenges that our industry is facing, what are you seeing in some of your most proud outcomes today when enabled with the tech that you have?
I think one thing that we see providers across the nation focusing on is how they can continue growing their census in the midst of a major staffing crisis. And we actually see this upstream of the home-based care market in the hospital systems that we work with through CarePort. And those systems are actually showing that the referral rejection rate has essentially almost doubled over the last 2 years post-COVID, as more and more providers are actually saying no to additional referrals from a hospital because they simply don't have the staff to care for patients. And so that makes it even more important to Tom's point earlier, where you want to be able to focus your resources on the patients that have the greatest need, but you also want to look for opportunities to potentially be more efficient in the patients that are headed towards a positive outcome. And so I think some of the encouraging things for us are that providers have been able to both decrease their hospitalization rate while actually reducing their amount of visits per patient. Doing those two things seem like they'd be in contrast, but if you can actually focus on the patients that need care the most, you can be successful. And once you use less visits per patient, you can use that same care resource to go out and take on a new patient. And so we actually see admissions and overall census growing as people become more efficient with their current staff, rather than having to worry as much about continuing to find new staff to care for the additional referrals that they want to take on to grow.
I'll jump in on the next one. Yeah, so well said, Wes, and we're doing a lot of the same things. Just a quick comment for you, Jeremy. We talk about Nana. A long time ago, my grandma was on hospice, and her name was Nana. And so when she passed away, we quit talking about patients and we started talking about Nana. So not to offend any of the papas or pappers or peepaws or any of those, but we wanted to use Nana to personalize it. So every time somebody uses the word Nana, and by the way, it's spreading across the community, it makes me feel good. And I know my Nana would be up there being proud to hear her name being called all the time. But to kind of discuss a little bit more with what Wes said, we're trying to figure out, all these hospice agencies and home care agencies are trying to figure out how to do more with less staff, even with rate cuts and all that. I would say the number one thing we hear is, how do we centralize? How do we do more in the back office? How do we have less back office people in the branch? How do we centralize the organization, but also be efficient? And so tools like what we're building here around AI and machine learning, and really looking at every single patient and predicting how many visits should we really be doing for Nana based on her disease cycle. And a Nana that's an 85-year-old, 5 or more polychronic medications, who has diabetes and congestive heart failure, who just had a hip replacement. Those are really complex patients. And so if you go and compare that to the other million patients that look just like Nana, we can try to predict that outcome and then give you guidance around the number of visits you need to do. So that's one, because we have to put that on the 485 or the plan of care. And then two, how do we make sure that the care that we are providing is working, right? And so by monitoring visit by visit, every time a visit gets synchronized back into the product or transferred or whatever you call in your technology, then we rescore that patient using the machine learning tools. And again, we're looking at millions and millions of patients, comparing them to the Nana, but then also the most important piece, I think, is comparing Nana to Nana. Under COVID, and what we've seen is we used to try to have exactly the same caregiver to go see the patient throughout the entire episode. Now we just need a caregiver. Just give us a nurse that's qualified to go see them. And so if you've never seen Nana before, is she better or is she worse than she was last time? Is her pain higher or lower? And so that's where we're using the tools in the field to make it easier for the clinician who shows up to see the patient for the first time. Is Nana worse or Nana better? And then how do we react to that as an organization to say Nana's getting sicker, let's do more visits or less visits? We need to change the care plan. We need to add social determinants. We need to bring in a physician and go see that patient. And so the tools itself are enabling care at the bedside. And everybody always talks about the intersection between healthcare and technology. That's really where we're at. Healthcare is the clinician in the field. Technology is giving you guidance. We're not replacing the clinician. We're not taking away their decision-making support. We're giving you extra data, highlighting the data that you need to look at, the things that are really important for you to help resolve Nana's problem. She's having pain, give her more pain meds. If she needs a catheter, give her a catheter. She has no food in the refrigerator, she's bedbound. If you don't eat, you're not going to survive. And so those are kind of the things that the tools really work on. But then highlight those to get away from alert fatigue. It's alert fatigue. Every patient gets, in the home health and hospice is sick, they're critical. But how do we give you the patients that are declining? So we call it the significant declining condition, not changing condition, the old SCICs, but significant declining condition. If we see that, how do we trigger you so you go do something different? Jeremy, you got anything to add to that?
Yeah, I do. I think really what we're all talking about is a sea change, right? So if any of you remember buying houses with the MLS books that had like a 3x3 picture of the front elevation of the house and then a number of rooms and the square footage, like that's how you bought houses like 20 years ago. Imagine not having realtor.com or Zillow or all the things. Like this is what we're doing in healthcare. And I think what Tom and Wes are describing here are the important parts that you guys can see, touch, and feel. And what's about to happen with these things that Tom and Wes and I are describing is not only can you see them and they're offering clinical decision support, right person, right care kinds of support, but they're also going to align to these reimbursement shifts that are occurring. And if you don't play this new way, then you're like buying a house in that 3x3 inch view. Or to use Moneyball, if you're familiar with the Brad Pitt baseball movie or any of the books, like it's the shift of scouting for how a person runs, throws, you know, what their physique looks like, to how statistically is this person going to do on getting on base or making strikes, right? Like that is the shift, and they're going to pay us to make this shift. And I think that's the aha for all of us, is that if we're wise as persons helping you make this transition and this sea change that's occurring, we're going to show you, like, do these things now while they're carrots, because the next level is sticks. They're going to come out with penalties if you don't perform. So today, here's all these bonuses you can make through change management by incentives. Tomorrow, it's here, you didn't do these things fast enough, you're going to get penalized. And you can look at primary care, you can look at the oncology care models, you can look at, you know, 20 years of sort of Affordable Care Act kinds of things that are taking shape. Like that's what's going to happen in this part of the market. And I think we're all here to help you guys through that transition.
That's great, guys. And I think you guys each touched on different components of, you know, outcomes. And Jeremy, it's hard not to sound morbid, pun intended, I guess, for this group, about, you know, how this is evolving in terms of really stating your value. But there will be sticks, and they're not just sticks in terms of reimbursement, right? It's also about, are you a preferred service? Are you going to be, if I, for example, am a primary care group that is managing, I don't know, let's just say 50,000 patients in multiple states, and I am looking in a specific region for a great hospice who can share data, who is value-based oriented, who understands that I'm going to be looking at specific formularies for my populations, and, or, you know, kind of trigger-based environments where we're not just going to write for more. We actually have to prove that need is there. And right. So, you know, Tom, this kind of comes back to what you're talking about, proof that need is there through the storytelling of Nana, but also the triggers for the providers to know that it's time. So I think that it's not just about the payment, right? It's also about becoming the chosen ones in certain regions. And so a health system knows that you can do it because you can prove it, but then you also are able to share information with them about what's happening when they're not in the hospital, when they're not in the clinic, when they're not, right. You know, and that's the part that I think is really, as I think about the future, as, you know, if I'm putting on my hospice hat or my home health hat, that is different. And so how are you seeing, what new things are your clients asking of you in that realm that you're really stretching to figure out? And, you know, Wes, you guys are started with, you know, kind of a broader client, and then kind of, you know, are tailoring services, and you know, have done some of that through acquisition of things like Tap Cloud, which is more of a patient-centered. But how are you guys thinking, and what are your clients asking for now that, you know, they may not have within your suite of services that are going to help them be a better preferred, I hate to say, maybe service entity or a preferred organization?
Jeremy, you want to go first, or you want me to?
Sure. That? I'll go first, then you can add on. So we see that the shape of the market, especially in the segments that we operate in. So I didn't describe this very well, I don't think, but primary care has taken a lot of the risk in these new world models, and the investments that they're making are in traditional primary care for the golfers and dancers, but they're also making really big investments in partners that do advanced illness care. And that shifts from $10,000 per patient per year in budget to $45,000 to $50,000, right? If you're not the chosen partner for that advanced illness care in your market, the old world way of doing pizza and persuasion in services, describing it to them and trying to win them through relationships to give referrals is not going to work, because you're going to be out of network and therefore out of mind. And so when we get asked for things that are like innovative, like what can we do to get more in that world? Luckily for us, because we have a foot in that sort of house calls based world with primary care at risk in clinic or house calls based arrangements, or I-SNPs or D-SNPs that are institutionalized patients at risk, That's one half of our world, and we clap hands with the other half, which is your post-acute service providers that need to be aligned under preferred partnership. So they ask us for, how do we get more at-bats? How do we get more attention? And to answer the question, it's, you've got to showcase that your value is provable. You've got to showcase dollars in return and savings type arrangements. You've got to showcase quality scores, not hospice to bear, but days at home, hospitalization rates, revocation rates, those kind of things. And so that's what we end up showing them. And then there's always the next step. How do I sidestep OIG audits? Great. Well, we know what Medicare looks for when they're going to audit you. We have all the data. Let's look and see if your operations are clean, so you're not doing hospice level things that it should have been reimbursed under that benefit are getting paid for under Part B or Part D. So that's the stuff we end up building incrementally on top of our tooling. And Wes, I think you have lots to add.
Well, I think a lot of it aligns to what you mentioned, Jeremy, and Katy. I think we've taken a little bit of a dual approach where there are participants that are really well entrenched and have leading capabilities, like on the hospital discharge platforms or with patient engagement. What we want to do is make acquisitions and then tie that data into that data platform that I mentioned. So today, if someone gets hospitalized in they're a home health patient in Austin and they go to Dallas for the day to visit their daughter and get hospitalized, we're able to have an immediate alert get sent to the home health provider that patient got hospitalized in Dallas because that hospital uses CarePort, and immediately will send an ADT notification of what happened to that patient. So that's one area where we're bringing in a new source of data. And then for patient engagement, we see with home health value-based purchasing in particular, if patient satisfaction is going to play a large role in actually determining your outcomes. And there you need to have, you need to go beyond just visit to visit communication. That's where we started. Instead of just having it based on OASIS, it was going visit by visit. But what we realized was, yes, you might have 3 visits in a week, but if someone falls on a Friday and you don't see them till Monday, or they're having exacerbations on Friday, you want to be able to know that sooner so that you can care more effectively for that patient. So that's why establishing that real-time connectivity with patients is important, and we can bring that all into our data sets. The one area where we've really looked to innovate and build are these things where we see gaps in the marketplace. So with our capability that we've developed called Team Insights, it's all about staff analytics and engagement and gamification, because we know that ultimately 2 or 3 years ago, providers were constrained by the amount of referrals that they could get. Now they're constrained by how many staff members do I have, and what is the likelihood that each individual staff member is going to turn over from their role or go to another provider. That's very valuable information for a home health or a hospice or a personal care agency to have.
Yeah, Katy, let me add to that just a little bit too, because it's kind of a different angle. But when you start looking at taking your Medicare Advantage patients and you're trying to figure out what that auth process is, and we've all heard the publicly traded guys, and I've talked to in the industry, lots of different providers that, it's 7 times harder to go get auth and track auth and get permission and all that. And when you really peel back the onion around that, you start looking at that's impacting the patient care, right? If I have to go get auth in order to see the patient, now it takes me a couple of days to get auth, or a lot of extra effort. And so what we've seen, we partnered with a company called PHCM. We've partnered with other companies out there to use the Medalogix tool sets to auto auth. So instead of you calling and begging for auth, or calling and requesting auth, you actually get the auth through the tool. The tools say you need to do 10 visits, you need to research this patient. And so the real challenge there is when patients got moved into home health or hospice from like a PHCN or another risk-bearing entity, they kind of went into a dark hole. And until they went back in the hospital and CuraSpan told you that they were back in the hospital, you didn't know what's going on with your patient. And so that's why they request, to give you 2 or 3 visits and you got to go do it again. And so we've actually opened up the door and said, here's the transparency of what's going on with NANA. Here's how we're looking at NANA after every visit, and allow the risk-bearing entity to see that data as well under of course, all the right HIPAA agreements, so that now we're not looking for patients that are We're not looking for authorization. By the way, if you get on the other side of that thing, the last thing they want to do is give you authorization because it's a very big burden for them to authorize. And so if we can tie this together, it'll take that burden off of both sides so that we can provide better care to the patient. And so I think that's where you're going to see this Medicare Advantage model, these other risk-bearing entity type models go, is to get away from trying to auth each other and trying to, get requests back and forth, and more sharing of data to allow us to do the right thing for the patient. Whether it's call a doctor, get DME in there, physicians, food, whatever it is. How do we manage the long-term care of that patient? More than just a 60-day episode, but how do we do a case rate or care rate for that patient?
It is definitely going to happen. And you've seen it happen in other parts of medicine, like just think of the kidney care world or the cancer world. And I even think of nursing home management and utilization and the Navi Health and what that did to utilization and facilities and institutional housing. And it's, it's happening to our industry in such a way that, it's going to be a big shift for the workforce. So, and moving from as a nurse practitioner to somebody saying, hey, you need to produce X amount of visits, to, hey, you're actually going to be held accountable for the quality of these visits. And we don't really know what quality looks like yet, but we think it's around this. And then, on top of that, there not really being industry standards or clear guidelines yet about what those benchmarks look like. And so I think you guys are starting to create some of these benchmarks that are unbeknownst to the provider world yet, that you're seeing through trends of outcomes with your clients. And so I didn't put that as a question on here, but I'm just thinking of some of the things that I've learned from you about benchmarks, and what we can expect, and even so much so that you understand how you might need to toggle your visit approaches for specific populations and effectively evolve your clinical model. Because if we aren't in the hospice world, or we're in a value-based sole environment where we aren't, having to provide governed amounts of services based off of what is expected, you can get really creative with your clinical modeling. And so I would say, in a value-based environment, the sky's the limit with that, because you can have multiple different types. So I think that anybody who's thinking about that space and evolving, their human talent into another environment where they might be able to be a good vendor, it's understanding some of those benchmarks. And do you guys have any fun in this benchmarks that have just surprised you and you're like, oh my gosh, I didn't expect that, but that's pretty cool?
Yeah, so maybe two questions that I think really you're asking. One is, what do the benchmarks look like that are surprising? And we've seen finally Medicare is moving the requirement of like submission and reporting out of the equation, and they can just look at claims data, which, why not? So things like hospitalization and then rehospitalization, and then hospitalization after an encounter that should have been managed at home, so days at home, those are the easy things for them to do all through claims. You don't have to document a thing. So those are the good ones. Then the other thing that I think you ask, and I'll just quickly tease it out here, is under these value-based care arrangements, everybody can work to the top of their license on the patients that need the top of the license, so a nurse practitioner or a physician. And you can bring in coordinators. It can be medical assistants, certified nursing assistants, and they can do 90% of patient care that doesn't require a physician or a nurse practitioner or a PA. And that's the clinical model change that we're being asked to support. And so those two things are the things I think we're being talked about. You ask about the quality measures, and then I think the other one is, what do we do that change our model? And those are great things to really spend some time on.
The other metric that upsets me, but we're fixing, is and you really deep dive into the hospice side is, and then if you read the MedPAC's reports and any other reports, they always talk about visits in the last 7 days of life and visits in the last 3 days of life. And it's kind of an embarrassing statistic for, I'm on the board of Trella and have looked at the Trella data for many, many years, which combines all the claims data. And it's 5.12 visits in the last 7 days of life. are the total number of visits. That's chaplain, social worker, aide, Reiki, everything, nursing. And when you really dig down to that patient's dying, they need more care. So we want 5 nursing visits or 7 nursing visits. We want daily visits for that patient who's literally declining and dying. If the family will tolerate it, we want to be there as often as we can. And so that's where, when we developed the Muse product, that was really the use case we were trying to solve, is how do we notify somebody that Nana's passing away, that Nana's getting very weak, Nana's getting sicker, one, so that we could, make sure the family's there. Like, let's make sure we're all around Nana. Let's make sure we get to say our goodbyes. Let's do all the right things there. But also the government wants us to do that, because that's when Nana's declining the most, when the likelihood for someone to pick up the phone and call 911 and put her in the ER and in the ICU, that's the last place Nana wants. And she's expressed that. But if we're not surrounding Nana with caregivers, then what happens? And so we've gotten that number up to 9.6. We put a couple of case studies out where, just by using predictive analytics and tools to show that Nana's declining, we can increase that number. That's what you want. Your star rating should go up, your HCI scores go up, but also the care for that patient is at a higher quality. And so that was the purpose of Muse when we developed it. My goal is to have CMS call me and thank me for that, but it's never going to happen.
I would just add that I think the visits in the last days of life is a metric that, I think our entire industry needs to do better on. And I think we have a unique opportunity to use analytics in particular to get better at that and help hospice organizations understand where to focus their scarce resource, which is, a skilled nurse or a physical therapist to go out, or anybody else to be able to care for an individual patient. I also think with the median hospice length of stay being, 7 to 10 days, we see an opportunity looking upstream to think about how could we identify patients who are potentially suitable for palliative or hospice care sooner than they're being identified today. Because still, our average length or median length of stay is less than 10 days. And then for only about half of all Medicare deaths happen on hospice care. So it's a big opportunity for us to think about how can we get more people into hospice, and how can we ensure that they have a good hospice experience. And that's an area where we're looking to start using some of these algorithms upstream in an Epic hospital or otherwise risk-bearing entity that's looking to think about how we get more patients where they really need to be, which might be palliative or hospice care.
I'm going to probably be Captain Obvious here, Katy, but if we build these case rates and these reimbursement models under the current methodology to extend the coverage of every one of our customers, Tom's, Wes's, mine, and yours, Katy's, when you're caring for a person for the last 2 years of life, all of those measures that we just talked about are going to naturally get better, because you're going to have built rapport, command and control, and Nana's going to have appreciated what you bring to the equation. This is the natural push by Medicare to push these programs out. So our lives will get, this is the thing that's so hard because it's a change. Like, if we could do change management well as humans, like, this wouldn't be so hard. But the thing that is going to happen is we're going to have to elongate how long we're covering the patient lives under a case rate model or an ACO type model or a managed care model, whatever you want to call it. It's value-based care. It doesn't matter what's named, whether it's palliative or any other home health or any other kind of thing. That's going to create a tethering of these patients that are in an advanced illness mode to a patient-centered quarterback level of care, where all of these things we're talking about are going to naturally improve, because we're going to see them for who they are as persons beyond just what we get in 7 days or 10 days of a median length of stay. Like, that's just not enough time for us to do the jobs we're asked to do.
Yeah, I agree. And, like, it is this, I love that you guys are starting to think about taking some of those benchmarks that matter to managing the workforce and the behavior of the workforce, to help them see it as a value add, meaning once I, for example, have 5 patients that are in the last 7 days of life, or let's just even say that I might be eligible as a community to have an additional support from X. And
Right.
that volume, instead of looking at patient load or how many patients does somebody have, how sick are my patients, and then what additional supports am I going to get in the event that they are sicker. And so it's a what's in it for them. The other thing is the idea of gamification. I will say, as a snippet to those who haven't done this yet, having managed both nurse practitioners, doctors, and clinical staff on the ground, is that gamification does work as long as the stick is not ominous and it feels forced. That it's really about making their lives easier and better. And over time, it does really work, and they want to see how they're performing, and they want to feel like they're performing better. And I also would say that you also have to have the humility as operators to know when to evolve what you've set forth and said, oh, we set the wrong benchmark here, I'm really sorry, and kind of pivot and move quickly with them. So it's, these technologies make it you capable as clinical operators to do that. We do have some questions coming through, and I noticed one in terms of predicting 6 months or less from death. Absolutely, all 3 of these technologies do that without a doubt. You are able to do predictive analytics for, mortality, for utilization, and I would say even caregiver risks and all different symptom burden risks. Medication and fall risk, you name it, a lot of the tooling will allow for that. So as providers, we're able to tailor and hotspot what we believe are the most needy patients and highest risk individuals. The other question that came through was about Medicare Advantage and them not really sharing claims data. So I'm a provider, let's say I'm a hospice or a home health agency. I want to prove my value, but I'm not an ACO REACH or getting that Medicare information, or the lag is so long that I'm losing out on contracts or capabilities. Are you building things and what strategies are helping bridge that gap for companies who really don't have access to that information?
Yeah, so I'll take the first crack at that. So Medicare Advantage won't ever give you their pay rates, because that's their intellectual property, what they've navigated through their version of payment methodologies. But they'll give you every bit of everything else. So all the utilization, medications, all of that. You need to be under a contract arrangement with them. They'll have a data use, a portion of that contract. If those 2 things exist, you can get it. You just won't get paid, which is fine. The other thing you can do is use approximate examples. Medicare will give you everything. So if you sign up for something called data at the point of care, any one of you that's doing a Part A, home health hospice, or Part B, palliative or primary kind of care, for all the patients you've seen over the last 18 months, the regs will allow you to get weekly updates from all care being provided where Medicare is the payer. So all Part A, B, and D. And it's at least an approximate, and it'll be a very good approximate for what Med Advantage is. And you can use that as another way. So get into these contracts would be sort of step 1, and work on that in parallel while you also get Medicare's direct data. The difference about that Medicare's direct data under data at the point of care is most of hospice is not billed daily like most of the rest of healthcare. Hospitals don't bill daily, but everybody else does. A super bill every day and UB4 every day. And so every week, Medicare is going to give you all that's happening in the oncology, cardiology, neurology, all those practices, all the primary care, and then the institutions will take 30 or 60 days. But that's pretty fresh data for you to have your eyes on to use as a means to sort of drive these kind of outcomes.
Excellent. I think I've got to most of the questions, but we had Canada. Are you in Canada? Anybody?
We serve some clients in Canada, but it depends on the benefit and what sort of data they're collecting there. So feel free to reach out. We love Canadians.
And we had another question come through, and I bet you this might be a clinician. I'm not certain, but there's always skepticism as a provider about how good your artificial intelligence is, because we just think we're smarter and better, because what it tells us is one thing, but what we see might be something else. But I think each of you have put a lot of time into democratizing clinical knowledge and or the best in-class standards. For example, the palliative performance scale that we use for prognostic risk or mortality risk. And Lolita asked, how do you integrate these types of things, and how do you know if and evolve it over time if it's not working?
I'll just comment on that quickly, and then I know Jeremy and Tom would add as well. I think it's really important to have both the clinical expertise and the analytics expertise working together. I think those two things are peanut butter and chocolate. They're better together. And what we see is, while I think having a clinical judgment by being able to use their best practice knowledge is really important, having an overall population dashboard that gets you real-time information and segmentation on your population, in addition to deep patient insights, those are things that one-off risk tables, I think, are going to be hard to sustain. Why not use all the data that you're already collecting today in the course of care and just make it more actionable and insightful?
Yeah, I would agree with that, Wes. What you just said is right on. The PPS score is answered by a clinician in the field. The other mortality risk scores are answered by one clinician. We're using 600 to 900 other clinical factors, including all the medications, the diagnosis codes. Every time you answer the physical assessment question around how risk is Nana to fall, does she have this disease, that disease, urinary incontinence, is she, all those, what's her pulse, vital signs, everything you're collecting in the field is then scored and weighted. And so it's more than just one question, one answer. My goal is to find it way faster than a clinician answers that question, because if I can change the care plan of that patient or the care plan that the nurse is providing that patient quicker, then their experience is going to be better. So not to say that these tools are bad. These tools have been around for a long time. But when you start using real machine learning and real AI, and you're comparing not only Nana to herself, but Nana to millions of other patients that look just like her, we can predict it a lot quicker. Back to your point of, are these real? And I love this question, and I get it a lot. Every time we roll out Muse or Pulse, or like, is the data right? There's always one patient that there's no way that, or one nurse, I've been a nurse for 30 years, there's no way. And I have a letter on my desk that I keep here, where a nurse said, there's no way that Nana's going to pass away the next 7 days. She's played bridge, and this is right when we rolled out, and you can still play bridge in some of the nursing homes. There's no way she's going to pass away. And the nurse, fought the system. 3 days later, she passed away. She wrote us a letter and said, you're right. Your product worked. I'm sorry. I trust it now. And so we always have those scenarios where, the software is trying to predict something's going on, and it's being challenged by a clinician. So we're not always saying, hey, we're always right. When we get it wrong, and we provided you a end of life in the next 7 to 10 days, and we missed, and you provided great care for 12 days, who cares? You're still the best hospice in the world. Or if you kept Nana out of the hospital because you did 2 more visits for her because she didn't go in the hospital, who cares? We're providing more care to that patient. And so when we miss, it's a better outcome than if you challenge the data and you don't follow the data, there's a different scenario there. But if you challenge the data and you continue to do more care, and the product says she's going to die in the next 7 to 10 days and she dies in 11, great. She lived 1 more day.
Well, and I've found all of you to be incredibly responsive to those types of questions too, when we're seeing trends and what might need to be tweaked. And Jeremy, I know that you use several tooling within your suite to help us, figure things out. And what I would say as we're at the 3:02 minute and Eastern time, is that I have learned a ton. I think that there are probably more questions about payment and how to budget for services like this and how to think it through. And I would tell everybody who's listening, there's not a one size fits all. Each of these companies have tailored their programming and services and product offerings to different types of entities and structures that are realistic. They want you to do well and learn with you. So I just encourage you to go on that curiosity journey of learning and reaching out. And I want to thank Hospice again and these 3 individual companies and gentlemen for spending the time to share what they are doing and up to. And Thank you to everybody who participated today as well. This has been an honor and so much fun.
Thank you, Katie.
Thanks, Katie.
Thank you, Katie. Thank you, everyone.